Thank you. It's a topic which I'm very passionate about. So I'm talking about kind of the next steps, how to talk about disease progression and prognosis in advanced breast cancer. And I think, as we've heard from the previous speakers, I think that it's really important when someone is first diagnosed with metastatic breast cancer to really help them understand what to expect. What does this mean? And I think just making it clear that for many people now, they're surviving for many years. They will nearly always be on treatment. I think that's an important thing. A lot of people sort of think maybe they'll just have a course of treatment like they did in early breast cancer, then it will stop. So I think explaining that you will, there's a good chance you will live for many years, but during that time you will nearly always be on some form of treatment. But that treatment will not work forever. And I think that's another thing to sort of try and help people understand, that they will be moving from one treatment to another. And I think some people use this analogy of the stepping stones across a river. You'll be on one treatment, it will stop working eventually, then we'll move to the next treatment. But fortunately, with metastatic breast cancer, we generally have a lot of treatment options. Most of our patients will be having scans every few months or more or less frequent, depending on how they're going. And for most people, cure is not going to be possible. So I think sort of making sure people understand that from the beginning will be helpful. Some people talk about the sort of journey of metastatic breast cancer as being like a roller coaster. So really that disease trajectory is very individualised, and it does vary depending on the subtype of breast cancer, the extent of disease, treatment response, and also individual patient factors. And I think it's helpful to prepare people for the likely ups and downs that are going to happen as they're moving through different treatments. There'll be periods where they're feeling very well and the treatment's working. There'll be periods where the cancer starts to grow. They may start to get more symptoms. We need to change treatment. So it often is this sort of roller coaster of ups and downs. And I think one thing that I sometimes find myself surprised by is this sort of unexpected deterioration. So it's a good thing now that many of our patients have very prolonged responses to treatment, and particularly first-line therapy. And so when that time comes that they have that first episode of disease progression, it can be quite a shock. And that can often be a shock for the patient, but also a shock for the doctor, because I think some of us get into this false sense of security that we've been seeing someone for a long time, they've been really well, the treatment's been working, and then suddenly it stops working. And I think it's often a very long time from those initial conversations that we had where we talked about the fact that the cancer wasn't curable. We talked about life expectancy potentially. And now it might be some years later that this first disease progression happens, and it can be quite difficult. And so I think that sort of raises this idea of, well, how should we remind people that treatment will not work forever, that the cancer cannot be cured, or should we be doing that? If someone's very well for years, should I be telling them every time I see them, don't forget the cancer's not curable, don't forget you could die from this? Like I think it's hard to get that balance of making sure people realise that this could happen, but obviously we don't want to be giving them this information every time we see them if they're well and living their lives. There's this concept of forecasting, so maybe just sort of telling people intermittently that things could change. So, for example, right now I'm hoping that the treatment will go well for you, but usually there comes a time when treatment is no longer effective, and I will let you know when that time comes. So that can be just a way of letting people know that at the time that I start to get worried, I will let you know. So moving to prognostic information. So I think this is really important for people with advanced cancer because it does help them make plans for the future. It helps with decision making. And I think communicating about prognosis is a fundamental skill for oncologists. But unfortunately, there's limited guidance to help oncologists do this well, and that's why workshops like this are really helpful. I think prognostication is daunting, so I think it is very difficult. We all find it difficult to have these conversations with patients. And I think because of that, often patients will be left with very little or no prognostic information. There are several barriers that prevent us discussing prognosis with patients. So we've surveyed Australian and New Zealand medical oncologists and asked them what are the things that make it difficult to discuss prognosis. And the sort of most common things that came up were family members requesting that the prognostic information not be discussed with a patient. That can be a difficult situation to navigate. For the doctor not knowing what the expected survival time is. So if someone says to me, how long am I going to live for? I don't know what to say because I don't know what the numbers are, so I just won't tell them. Limitations of time in the clinic, we're all really busy. We often have very short amounts of time to see people. These conversations can take time. Maybe it's easier just not to have that conversation. Fear of upsetting patients and their family members, and fear of getting the estimate wrong. What if I give them the information and I'm wrong? So I think when we're sort of thinking about when and how to discuss prognosis, like some of the other speakers have said today, I think we need to start these conversations early. So I think right from when someone is diagnosed with their metastatic cancer, rather than waiting for the patient to ask for the information, offering the information, saying something like, would you like me to talk about what the future might look like? Is there something else you would like to discuss? Some people in this situation like to know about survival time. Is that something you would like to know? So I think it's up to us to offer the information rather than waiting for people to ask, because it's not an easy thing for a patient to ask the doctor about. And I think prognostic discussions are really an ongoing process. They happen over several conversations, often over a long period of time. And one of the nice things about sort of treating people with metastatic breast cancer is you do often develop a relationship over often many years. So you do develop this rapport and this ability to have these conversations. And so over time you can discuss things like a person's values, their priorities, their preferences, their wishes. You can talk about the importance of palliative care services, end-of-life care, and also understanding how a person ranks longevity, comfort, and independence. We've conducted a systematic review looking at the optimal timing of having prognostic discussions, looking at 58 different studies, a collection of guidelines, studies of what doctors think, studies of what patients, people with advanced cancer think, and there's several sort of key time points that come up. But I'd sort of like to just focus on the two that I've marked there. At the time of an important transition, such as disease progression, I think that's an important time. And when we think a patient's life expectancy is less than 12 months, so if we think this is the sort of person we should be starting these conversations with. I think that most of our patients are having regular scans to estimate or evaluate their treatment response. And I think when we're organising scans for people, it's really important to explain the reason we're doing the scan, what the results may be, and what the plan is for good news and bad news results. So what will we do if the scan shows things are still responding? What will we do if the scan shows the cancer's growing? So having those discussions up front can be helpful. Acknowledging scan anxiety, we know this is a real phenomena. It's very common, it tends to be transient, and the peak times for scan anxiety are while people are just before their scan or waiting for the results. So I think we need to sort of organise a way we're going to deliver the results to our patients and avoid delays in that time. So try and organise a consultation to give the results as soon as possible after the scan's been conducted, ideally face-to-face. In Australia, fortunately, we don't yet have this situation where patients can receive their results in the middle of the night. I'm hoping that doesn't come to Australia, but I'm fearing it will. But I think that's a different challenge that we could certainly discuss in the next section. When the scan shows disease progression, I think it's critical for the doctor to be prepared. Check the result before you see the patient. So don't get the patient in the room and then start looking for the result and then you find it's progressed. And I think you need to know what that result is before the patient comes in. Be prepared for what your plan's going to be. Give the results straight away. So the patients are going to be so anxious about that scan result that as soon as they walk in the room, you really need to give them the results. I have the results of the CT scan you did yesterday, and I want to go over those results with you if that's okay. Express solidarity, so something like, I wish I had better news, if this is a cancer progression. Give the bad news clearly and succinctly and don't use too many technical terms. So unfortunately, your cancer has spread to your liver. And then I think pausing and giving the patients time to absorb what you've just said. I think a lot of us try and sort of protect the patient and minimise the bad news and change the subject. And I think you really need to stop and pause, and maybe there's going to be some silence there while this news sinks in. And then reassuring the patient that you're going to help them figure out what the best next steps are going to be. So when the scan shows progression, we know there's a tendency for oncologists to focus on discussing the next treatment. I know that we often will do this. The scan shows the cancer's growing, so then we'll just launch into this big discussion about, well, the next treatment I think we should go for is this, and these are the side effects, and this is how it's delivered. And one study has looked at this. They've looked at bad news scan result encounters and found that treatment talk actually occupied 50% of the consultation, and only 4 of 33 encounters actually had a discussion about prognosis. And I think this is really a missed opportunity, because I think when the scan shows the cancer's progressing, that's really a time when we can sort of take the chance to ask a patient about to talk about the prognostic implications of that scan and get this patient to sort of reassess the priorities, goals, desire for information. So just simply asking something like, would you like to talk about what this means before launching into the next treatment? So again, this forecasting concept. So your cancer has progressed, but we still have a treatment option. Have you considered what you want if this treatment does not work? If there is an emergency situation, have you thought about what you want to be done? So these are the kinds of questions you could ask at the time of a scan showing cancer progression. We know that patient preferences for prognostic information vary. The type and amount of information changes between individuals and also within an individual at different times. Some people just want the big picture. Is the cancer curable? Will this shorten my life? Other people want lots of details. They want numbers, percentages, best case, worst case. So we really need to find out what information do people want, what type of information, so we can give it to them. And then there are going to be people that want no information at all. And I think that asking why can be helpful, so just understanding why they don't want that information can help us understand that. But again, as our previous speaker said, I wouldn't be confronting people who don't want the information with this information. We've asked patients about their preferred format for receiving information about life expectancy. So we did a survey of patients in Australia. We gave them 2 different formats to explain survival to a hypothetical patient who had a median survival of 12 months. And we gave them this option as 3 scenarios, so explaining best case, worst case, and typical scenario, or just an explanation of the median survival. And we found overwhelmingly that our patients preferred to receive that 3 scenarios format rather than just that single number. And we've subsequently developed a website to help doctors estimate and explain those 3 scenarios. So if an oncologist puts their estimate of survival into this calculator, it will then sort of calculate the best case, worst case scenarios and create a printed format that the patient can then take home. So like we've said today, it can be helpful to have written information, because often people will go home and just focus on potentially the worst case, or they didn't sort of hear anything, didn't sink in. Having that information to take home, we find, can be helpful. We've actually done a study where we've used this website to give people their information formatted as 3 scenarios. So this is again just for people that want quantitative information. And we found that overwhelmingly people found this very helpful, and they also found that printed summary very helpful. We found that people did like to receive all 3 scenarios, including the worst case. So I think we're often afraid to give the people their worst case scenario, but patients do want that information. And we also found that most people, the information they were receiving was what they expected, the same or better than expected. So we weren't telling people things that were a lot worse than they thought. And I think one of the other reasons that doctors may hesitate to give information is we're afraid of telling people something that they're not expecting. But actually, most people are probably going to be thinking worse or the same of what you're going to be telling them. This is another website I've been involved in, which was really designed for patients to look at for survival times, but it's also helpful for doctors. This is sort of a website that's been developed for all different types of cancer, different stages. And you can sort of put in some general features of the type of cancer, the age of a patient, and it gives you information based on SEER data. So it's sort of collections of real-world patients followed for survival for up to sort of 10 years. And it gives sort of 10-year, 5-year, 2-year survival sort of models. So that's another good website that is more reliable for patients who are often Googling, how long will I live for? This is information that's a bit more reliable for them to receive. So just to finish off, I think that it's really important that we help patients understand the likely trajectory of metastatic breast cancer. I think conversations about prognosis, values, priorities, and end-of-life wishes are really important and need to be part of routine care. I think the absence of questions does not equate with unwillingness to know, and it's really up to us to make sure we're offering people information and offering to discuss prognosis. I think there are key time points that we should be seeing as triggers to start these conversations, in particular when we see that the cancer has progressed or when we think someone's survival is likely to be less than 12 months. And I think importantly, we need to acknowledge patients as individuals, and everybody has unique information needs about the timing and the type and the amount of prognostic information we want, and we need to find that out to make sure we're giving them the information they request. Thank you.